Dr. Kataria with one too many complications of myocardial infarction.
Good morning. Thanks for having me here. I'm excited to be here and talk about this case of one too many complications of a myocardial infarction. There we go. So 55-year-old male, unknown past medical history, suffered an out-of-hospital VF arrest. No bystander CPR was performed. EMS arrived, found him to be in VF, and they followed the ACLS protocol until ROSC was achieved. He received a bolus of amiodarone and was brought to the MGH emergency room. This was his EKG on arrival, and as you can see, ST segment elevations in the inferior leads with ST depressions in the high lateral leads. He became unresponsive once again in the emergency room with clenching of his jaw muscles, occasional posturing. He was intubated but continued to be hypoxic, for which reason we had to actually disconnect him from the vent and perform bag mask ventilation. He also had recurrent hemodynamically unstable VT, requiring multiple shocks while in the emergency room. He was hypotensive, for which we started vasopressors, levo, and vasopressin. And then the shock team was consulted and sort of came together in the emergency room to discuss next steps. These were his labs on arrival, and I guess they're pertinent for hypokalemia, potassium of 3.2, which was repleted. His creatinine on presentation was 1.1. His LFTs were slightly elevated, so the upper limit of normal being in the 40s. It was about 88 and 82 for AST, ALT. His high sensitivity troponin was greater than 3,000, and his NT-proBNP was greater than 5,000. This was his X-ray on arrival. Retrospective vision is 20/20, but this is what we looked at and sort of moved on. The decision was made to obtain a head CT prior to proceeding with next steps and bringing him to the cath lab. The head CT was negative for acute intracranial hemorrhage. He did, however, have 2 more runs of VT while in the scanner, for which he was shocked. Great, so these are playing. So these are his cath films, and as you can see, some minimal irregularities in the circumflex. And then if you look at the LED, basically a mid-LED lesion of about 60% after takeoff of the large third diagonal. So the left main was patent, minimal irregularities in the left circumflex, as I mentioned. LV-EDP was measured and was found to be elevated, so an Impella CP was placed. And then the right circulation was shot. So as you can see, we have a mid-RCA abrupt ending or occlusion. And this was actually described by the interventionist as being a heavy and organized burden of thrombus, which was extending into the RPDA and RPLV. Here's a cine image of the final result, where you can see that I think most of that, it looks like a good TIMI-3 flow. A lot of the thrombus burden was sort of pushed distally, and you can see the Impella that was placed. So right heart cath was performed at the end of the procedure. His biventricular pressures were elevated, right atrial pressure of 18. His PA pressures were 69, 29 for a mean of 44. His wedge pressure was 20. The stats that were measured were pertinent for an SVC stat of 57 with a step up in the mixed venous stat of about 76%. These were repeated. They were still discrepant. There was actually a TEE performed inter-procedure, and no shunt was noticed. So this was sort of mentioned in the report, and the patient was then transported to the surgical ICU with a recommendation for aspirin, and we maintained him on a cangrelor drip at that point, since he was intubated and wouldn't tolerate PO meds at that point. So his course in the surgical ICU, COVID-19 positive, we initiated therapeutic hypothermia, because at that point his neuroexam was still not great. As the day went by, he was noted to be having worsening hypotension, lactic acidosis, shock liver, and decreasing urine output. As for mechanical ventilation, he was requiring 100% FiO2, so obviously something was amiss. His exam was then, we've talked a lot about the stethoscope, so at man's greatest hospital, we picked up our stethoscope and actually found that there was a harsh holosystolic murmur, but again, this was day 1 of his admission, and I'm not sure what was heard in the emergency room. His mixed venous oxygen saturations were persistently elevated in the 90s. Again, his X-ray, I just keep bringing this up more from a teaching standpoint or learning standpoint rather. So the X-ray looks like this. You have an inferior MI. You should really stop and think, what's going on? This doesn't add up. So his pressures at the time, his filling pressures were slightly less reduced compared to what was seen in the cath lab. So his CVP was 11 to 15. His PA pressures were 40s over 15 for a mean of 23, and he was quite hypotensive. So that's sort of when we obtained a surface transthoracic echo, and as you can see, and this is what I'm told, is in the emergency room, the right ventricle, the right side of the heart did not quite look as dilated, but it definitely does on this surface echo in the ICU, and we also have a significant burden of tricuspid regurgitation. So this was felt to be a change compared to when he first presented. And these, yeah, Dr. Carr guessed it right. So we have a VSD, which is inferobasal in location, and you can see there's a significant shunting. It kind of looks bidirectional at this point, and that's our Impella CP that you can see on the echo. So our shock team sort of decided, we've talked a lot about tandem heart this morning, but at our center, I think it's more VA ECMO heavy. So we went ahead with cannulation on VA ECMO, and Impella CP was left in place for it to be an LV vent. Again, we talked about ECMO potentially adding to the afterload. So we had the Impella in place. We continued aspirin and cangrelor. Unfortunately, at this point, he was anuric, and so we had to initiate CRRT. His repeat COVID-19 PCR was negative. I really don't want to get into COVID, to be honest. On hospital day 7, he was taken to the OR for a VSD repair and one vessel cabbage, so we did actually address the 60% LAD lesion, and cangrelor was continued perioperatively. So he was extubated on post-op day 1. He was transitioned to clopidogrel on post-op day 4. He was transferred out of the ICU on post-op day 5. He subsequently recovered his renal function. He was participating in physical therapy. Everything was looking good until around midnight of hospital day 20, he becomes unresponsive after being helped back into bed after using the bathroom. He's bradycardic and then has ventricular arrhythmia. CPR was initiated at the bedside. 25 minutes into CPR, we still did not achieve ROSC, so we performed, again, VA ECMO cannulation as part of eCPR. This was his EKG at the time. So just as a side, something that I did not include in the slides was that he had developed a hemothorax, and a couple days prior to this event, we had actually held off his DAPT. And the reason for that was that once he had had the VSD repair, there was ligation of the portion of the RCA that was responsible for the initial infarct. And so it was felt that DAPT was probably not essential at this point. So obviously the concern was there some kind of stent thrombosis that was going on? So we looked at an EKG, and as you can see, there aren't any ST segment elevations that we saw. So TEE was performed as part of the ECMO cannulation, and lo and behold, he actually had that flailing tap muscle and severe MR. He was urgently brought to the OR for a right axillary Impella 5.5 to go with the ECMO. 2 days later, he underwent a reduced sternotomy and a tissue mitral valve. ECMO was decannulated around 5 days after the initial event, so on hospital day 25. And then subsequently, 2 days later, his right axillary impella was removed. After a prolonged admission of around 4 months, he recovered his renal function, he was discharged to rehab, and I'm happy to say that he actually made it home recently. So yeah, thank you. I've left out the discussion, happy to take questions. And can I just ask, did you guess the second complication? Okay. Because I could hear you, like you knew the first one, which I think was not. I mean, I think, retrospect, I think it was, yeah. Okay, that was totally unexpected for us too. And I will say that we kind of reached out to our surgeons to ask about this, and they did think that the tissue, and we've talked about this a lot, about the tissue being mushy in the beginning, and the tissue was, and the surgeon wasn't surprised that there was that second complication, because the mitral valve, the region of the mitral valve apparatus was involved in that mushy tissue. I wish I had seen it, but yeah.
Dr. D'Alessandro?
No, actually, it wasn't him, no.
So, quick question. So, number one, that was amazing that you guys were able to capture almost every complication that you can potentially encounter. Thankfully, he survived, I hope. Second thing being, hospital day 7 for the operation of the actual VSD in the setting of it being inferobasal close to the mitral valve. What was the discussion like, and was there any discussions about maybe holding off and allowing the tissue to continue to recover, or what was the thought process at that time?
Yes, I think, personally, I feel like having been part of these discussions, I don't know that there is a number. To be fair, we made it to 7 days. He was on ECMO. ECMO comes with its own complications. Now he's on dialysis. We know that there's this LAD lesion that we were potentially interested in addressing. So I think it was just a combination of all things and all factors considered that we figured we would just go for it. I think, what I've learned myself from the discussion yesterday by Dr. Ramani, I hope I'm not butchering her last name, on VSD, and then lots of the cases presented this morning is I don't know that we know when is the right time to go in.
Yeah, I think so there's some papers to suggest that maybe there's a 14-day mark or even extended period of time where mortality benefit or whatever mortality that they may even have, you have a better chance of survival 14 to 21 days post, particularly post-MI VSDs. I don't know if they actually captured the whole papillary muscle rupture as one of that, but was there any notion of any even hint of regurgitation at the time when they actually fixed the VSD?
Yeah, great question. So no, other than the fact that there was visualization of the apparatus being involved. We had a couple echocardiograms between the VSD repair and the second complication. He had maybe mild MR, so there was no harbinger. Like we did not see this coming. So to say, yeah.
So I'm going to ask my surgical colleague about his thoughts about timing, and Dr. Carr had a comment as well.
Yes, absolutely.
Yeah, so there is nothing written on stone. And, our experience here in UT Memorial Hermann, we wait for a couple of weeks. The idea is theoretically, right? You have the fibroblasts coming into the picture and, with this inflammatory response of healing, give you a better substrate for repair. So in general, we wait at least a good 10 days to 2 weeks, or try to. We use the tandem heart, and the only occasion that we are forced to go early is when there is a sign of systemic inflammatory response. So then we go earlier, but otherwise we like to wait at least good 10 to 14 days based on Dr. Carr and Dr. Gregoric's experience from before.
Gotcha.
Sir.
Thank you.
No, I was just going to ask, on the original presentation, when you did the right heart catheterization, did I understand there was actually a step up that was actually a CVP NFPA pressure? So there was evidence of a left or right shunt at that point?
Yes, based on those numbers, yes. And I could start hearing Dr. Carr, like, all right, when are you getting to the VSD? Yes, absolutely. And like I said, there was actually a TEE intra-op. But again, I think that speaks to the fact that TEE may not be the best tool for, especially depending on the location of the VSD, we missed it. But again, this was mentioned in the report. This was signed out by the interventionalist to the ICU attending. And so this was something on our minds. And obviously, when we saw repeated mixed venous sats of 90%, you think about this and you wonder that something doesn't make sense. And so we missed it at first, yes, definitely.
Yeah, and I think you bring up a great point. Dr. Nathan and I, we kind of are involved in the imaging aspect of our structural program as well. So what we noticed is with these VSDs, you'd really have to get to the gastric views. And even in that, especially LAD versus RCA-mediated VSDs, one takes a very serpiginous turn versus one may be something that's a little bit more typical and easier in terms of an intervention. And we've struggled with isolating exactly where it comes from, particularly the mid-esophageal views, or when you try to get up into the actual esophagus, it's almost nearly impossible to find. So we go through each and every depth in the gastric component to see where it is originating from and try to delineate that a little bit better. So it is very challenging.
Yeah, and we did not have gastric views. You're absolutely right. Yep.
Yeah.
To be fair to them, post-MI VSD is a dynamic process. You may have a very trickle in the beginning, and we have demonstrated in our papers also there is a 30 to 60% increase in the size of the VSD over a week's period of time when we wait. So it's possible that when you saw, of course the X-ray was a telltale, but still you could have missed it easily, and then when you repeated an echo later, you could easily see it because it grew in size, and that's how your patient deteriorated. But the comment I wanted to make was in COVID, I'm sure all of us are seeing after COVID, we are seeing much more mechanical complications of MI because they're appearing late, and we are seeing this late complications. And I think I saw a paper from New York, out of 150,000 patients, there was a 139% increase in mortality after cardiovascular events during the COVID period
Yeah.
because of the delay.
And actually, my first VSD was during the first surge of COVID.
That's just
It was a
amazing.
woman who just didn't want to come to the hospital, and by the time she did, she had a VSD as a complication of her.
So apart from all the destruction with COVID and the deaths, which is approaching 1 million now, I think if we factor in all the cardiovascular deaths that happen, which is the number one killer, it's a staggering number.
Yeah, absolutely. As the advanced heart failure team, we did consider transplant or, advanced therapies, but we were only involved after the second complication, and there were social barriers, so in case anyone's wondering, but that was sort of why we did not go ahead with that at that point.
The greatest case is, the mortality of post-MI VSD is 50%, mortality of post-MI MR is about 88%. So total mortality should be 160. That means the patients are dead and the surgeon is dead also.
Yeah.
Before we do Impella, do we do LV-gram?
And actually, as I was watching some of the other cases, I was trying to think hard, but I don't think we had one.
That would have given another clue.
Yeah. I will say though, and to Dr. Carr's point, we wondered if there was progression and, a rather quick progression based on, again, I agree that the hocus pocus is, it depends on who's using it, it depends on the setting you're doing it in, et cetera. But the feeling was that the right side did not look as bad as it did on day one, or well into day one. So I wonder if there was a significant progression between when he first presented. And he had been having chest pain for 3 days, which is something we found out later on when he was able to speak with us. I'm not sure if that LV-gram would have necessarily shown us something, but I agree with you with the step up, maybe that could have been something else.
I guess he's talking about the MR.
I'm sorry, I can't see you, but I can hear you. Yeah.
If the suspicion is delayed presentation, you want to do LV-gram to rule out thrombus before you putting an impeller.
That's a good point, yes. But I'm pretty sure we did not have one. We had an echo, so I wonder if that was enough imaging for us from a thrombus standpoint. We definitely did not do an LV-gram.
I think Dr. Carr's point is really one of the other teaching pearls was kind of hidden in what he said, coming from Yoda there, is that so many of the things that were almost historical references in terms of complications subsequent to an MI have now become fairly common again. I would say that we probably saw more mechanical complications in the last 2 years than we probably saw in the last 15 years combined. Would you agree with that, Dr. Carr? So, great point. It really, we should have a higher index of suspicion than we probably used to, again.
Yeah, for the fellows in the room, smarter than me or whatever, but like the X-ray and the step up, if those are the two things that you take home with you from this case, then I think my job is done. But yeah, absolutely.
Awesome. Thank you.
Thank you.